The Quad Caucus is a convening of the 4 national caucuses of color: the National Asian Pacific American Caucus of State Legislators, NAPACSL, the National Black Caucus of State Legislators, NBCSL, the National Caucus of Native American State Legislators, NCNASL, and the National Hispanic Caucus of State Legislators, NHCSL. Over the past year, issues around equity have been elevated, particularly those linked to health equity, with alarming death rates among Black, Brown, and Native communities due to COVID-19 pandemic. Fueled with anti-Asian sentiment and a policing crisis, racism became easily identifiable as a public health crisis. Now more than ever, the collective efforts of the over 1,400 state legislators of color to prioritize equity, exchange information, and support each other is crucial to the policies that will improve outcomes for all communities of color. We are delighted to have over 200 participants join us for today's discussion. Before I introduce our speakers, I want to review a few housekeeping items. Today's town hall is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free to type your questions and answer any questions in the chat box on your screen. To begin building some comfortability with the chat function and to also learn who is on the line today, I invite you to type in the state from which you're joining us. We will hold a formal Q&A after our esteemed panelists answer a series of questions. So we have folk using our chat box function. Let me mention also that today's town hall is being recorded and will be shared with each caucus, along with the joint statement we will announce at the end of this town hall on behalf of the Quad Caucus. Today's town hall is sponsored by Amgen. In addition to this town hall, Amgen is supporting a partnership between the Quad Caucus and the National Conference of State Legislatures to convene a health equity advisory group. This group provides feedback to NCSL program regarding health equity resources available to all state legislators and staff and members of the Quad and NCSL. This is the first of its kind project, and we thank Amgen for their commitment. Please join me in watching a short video with Tamika Jean-Baptiste, the Executive Director of Diversity, Inclusion, and Belonging at Amgen. Please join me in a virtual welcome to Ms. Jean-Baptiste as well for a few words afterwards.
When I got the role, a lot of people congratulated me. And I feel like when it comes to diversity and inclusion and belonging, it's about we. And I really feel like for us to do what we all are hoping to do at this organization, it's going to take a collective effort. I'm Tamika Jean-Baptiste, and I am the Executive Director of Diversity and Inclusion and Belonging at Amgen. Growing up as a child, I really marched to the beat of my own drum. But it was my mom who really taught me to embrace my uniqueness and didn't want me to kind of conform or feel I needed to fit in the box. She also instilled in us a responsibility to make sure you create a space for people to bring who they are uniquely to the table. Even in my professional journey, I knew clearly when I was a part of teams where I feel like I had a voice, where I felt like that what I had to say was respected and valued. And I've also been a part of teams where I didn't feel that way. So I think it's important to recognize that the journey of diversity and inclusion and belonging, it is just that. It's a journey, and it takes consistency and persistency. There's just small behavioral shifts that I think you can make in your leadership approach, in your team dynamic. A lot of low-hanging fruit opportunities for us to continue to expand and evolve. Talent is demanding and expecting to come to corporations that have environments where they feel like they can come and be their best selves. And that's one thing that I've appreciated about Amgen is like we've never settled for second best at anything, right? We've always looked for ways to be the leader in innovation, the leader in what we deliver to patients. And I would say the diversity and inclusion is something else we don't want to be second at either. I'm very optimistic about the future. I mean, if you do it right, diversity and inclusion is the lens you look out of to make better business decisions. So to me, there are some things that are just innately in Amgen's DNA. Diversity and inclusion is how we do business.
Welcome, Ms. Jean-Baptiste.
Thank you so much, Representative Mitchell, and greetings to the officers, members, and legislative staff of the Quad Caucus. We are honored to be a part of this historic town hall event at what I feel is a historic time in our society, with a coalition dedicated to promoting equitable outcomes for people of color. We feel it is important at Amgen for us to not settle for second best in achieving health equity and promoting justice for underserved communities. We are also pleased to commit our people and our resources in this unique national dialogue that brings legislators from around the country together with healthcare stakeholders like the American Medical Association and others in a common quest for social justice. Millions around the world are galvanized in the demand to end systemic racism and the public health crisis it has led to. The time is now, and we look forward to this dialogue, and more importantly, the actions it will lead to in state legislators nationwide. So thank you, Representative Mitchell, for this opportunity, and I'll turn it back over to you.
Well, thank you. And it is because of companies like yours, Amgen, that I too am excited about the future. Thank you once again for making this town hall possible. Now, we're honored to have two experts join us today. Aletha Maybank, MD, MPH, currently serves as the Chief Health Equity Officer and Senior Vice President for the American Medical Association, AMA, where she focuses on embedding health equity across all the work of the AMA and leading the Center for Health Equity. She joined the AMA in April 2019 as their inaugural Chief Health Equity Officer. Dr. Maybank previously served as founding director for the Center for Health Equity in the New York City Department of Health and Mental Hygiene in 2014, and the Office of Minority Health in the Suffolk County Department of Health Services in 2006. She is a nationally recognized speaker, writer, and advisor on issues related to health equity, the future of medicine, and public health impact. Glad to have her, as well as Delegate Pina Melnick, has served in the Maryland House of Delegates since 2007. She is the current vice chair of the Health and Government Operations Committee, a leadership role following the traditions of that Chamber's House of Representatives. She is also the vice chair of the Maryland Legislative Latino Caucus, the chair of the Public Health and Minority Health Disparities Subcommittee of the Health and Government Operations Committee, and serves on the Government Operation and Estates and Trust Subcommittee. As a state legislator, she has focused on protecting consumers, reforming the criminal justice system, helping working families make ends meet, and championing the Medicaid expansion to help Marylanders afford health insurance. As part of her commitment to diversity and inclusion, she co-sponsored a bill to prohibit discrimination based on gender identity in public accommodations, employment, and housing. As the floor leader, she defended the bill from challengers during a vigorous 4-hour floor debate. We are honored to have two women of color that are moving the dial on health equity. Let's jump into a productive conversation with both of them. First of all, welcome to you both.
Thank you. Awesome to
Dr.
be here.
Maybank, please tell us about the formation of the Center for Equity in the American Medical Association. What led to its creation and why now?
Absolutely. Thank you. Well, thanks to the caucus for inviting me to speak today. Thanks to Amgen, and thanks to you, Representative Mitchell, for hosting and moderating this conversation. So just for those who may not know about American Medical Association, it is the largest organization that represents physicians in the country, about 270,000 physicians. And about, I would say 3 years ago in 2018, the House of Delegates came together, put forward a resolution and said we need to do more work that's intentionally focused on equity. Now, we as AMA have started work on equity and justice and a little bit of reckoning of our past in 2008. Many may or may not know, AMA definitely has a history of structural racism, contributing to structural racism in the scientific community, and also institutional racism demonstrated by excluding Black physicians for over 100 years from the institution. And so in 2008, an apology was issued by the president of that time, Ron Davis, directly to NMA, the National Medical Association that was created because of the exclusion, saying that we need to right our wrongs of the past. And so over the years in between then and 2018, there's definitely some movement forward, but we needed to do more. And so they explicitly came together and said we need to have an organizational unit that was going to focus on doing this equity work and hire somebody who's going to be fully responsible for doing this. So that was really the creation and how we came about. And I think the timing, honestly, could not have been more perfect. We could have done this, as many organizations like years ago, of course. Structural racism has been happening for centuries, right? But this is the time, and this is a movement that is happening, especially on the healthcare side. Public health has done this a little bit more. And so now over this last year with COVID, more people are exposed to the realities and the existence of inequities that are experienced by communities of color. More people now are exposed to, or better maybe appreciating, naming it. All of it's been here, but naming racism since the public murder of George Floyd. And now we see the continuation, the public continuation, of course, of the realities of police brutality and structural racism connected to that. So the country is really, I think, also at this time of reckoning as it relates to its racial injustice of the past and of the present. And so we are, I think it's responsible, and we have an obligation as the American Medical Association to be a part of this work of reckoning, to be leading in this work of reckoning, understanding our own contributions and our past realities of how we came to this space.
Good to hear. Delegate Pena Melnick, let me give you an opportunity to respond as well. And welcome.
Thank you, and thank you for having me. And I would like to take a minute to thank NCSL and the Quad Caucus. And it's really an honor to be on this amazing panel, very impressive. Look, what we learned in Maryland is the following, that we knew we had health disparities, but as a result of the coronavirus, this is what we learned. In Maryland, we have 6 million people. We have 23 counties in Baltimore City for a total of 24 different jurisdictions, 24 different health officers, right? And what we learned was that the county with the highest number of COVID-19 cases is gorgeous Prince George's County. So Prince George's County, who lives there? Basically, the majority of the residents are people of color, are Blacks and brown. And what did we learn? That not only did Prince George's County have the highest number of COVID-19 cases, but that the zip code in the entire state of Maryland with the highest number of COVID-19 cases is 20783. Who lives there? The immigrant Latino community. So as Dr. Maybank stated, we cannot be blind. The numbers are there. We must not ignore the science. So this is the time to act. So we in the legislature basically got together, and the Senate put together a work group that will look at the racial disparities, and the House as well. And we started to break down the data because there's so much data that would tell you who's being affected. And it's not just having access to healthcare, it is all those social determinants of health, like the way we live. I know that I dealt with families that 10 people in one apartment were all positive for COVID. It is that they're all essential workers, not having transportation, the education, and this is the time to act. This is the time to act, and we need to do it now. The time is right.
Delegate Melnick, let me just propose a question to you. session recently adjourned. What's the status of your health equity package? What are some of the lessons for your legislative colleagues participating in the town hall? And how did you overcome challenges, and what opportunities presented that you may want to address down the road?
So after we saw that data, we decided to try to do something about it. So in Maryland, we have the state IT department, CRISP, that keeps a lot of data, right? So you know who goes to the hospital frequently, who has the chronic illnesses. So what I did was I put together a package of 4 bills: House Bill 28, House Bill 78, House Bill 309, and House Bill 123. And I asked an amazing, the Speaker Pro Tem, African-American senator, to please cross the bills with me. So we started 6 months before session, and we brought together, like we are right now, there were Zoom calls that we had 30, 40 people on the Zoom call. I brought the hospitals, the doctors, you know, MECI, the different boards, the Care First, actually, in Blue Cross and Kaiser, all the insurers, the Maryland Insurance Administration, a lot of the nonprofits. And we started to talk about what can we do with this data? You know, how can we decrease these disparities? So we thought about putting in a bill, House Bill 28, that requires implicit bias training for all healthcare providers in the state of Maryland. That means it's not just doctors, nurses, anyone that touches a patient, anyone that is licensed by the state of Maryland must take implicit bias training. So then the board started to say, well, you know, we can't do that, it's too expensive. Then I said, well, why, let's compromise. Why don't we say when you have to, you know, renew your license, you must take the course. So that was a compromise language, and that's how the bill passed. And then we also have the Office of Minority Health and Health Disparities. And we've, you know, realized that we don't really have a serious commitment about funding it, because for so many decades, public health has been underfunded, and we must fund it and be serious about it. So the bill, House Bill 20, not only does it require implicit bias training, but it also requires a appropriation on the annual budget by the governor, that they must appropriate at least $1.7 million or 0.012% of the total budget for Medicaid, because we must be serious about it. And basically, I brought the Department of Health to the table, and I explained why this was important. And again, I would urge my colleagues to look at the data and use the data, because they can argue with you about it. So that is one. So that's House Bill 28, and it passed the Senate and the House. We just adjourned on Monday at midnight, and it's at the desk of the governor for him to sign it. The other bill I put in is House Bill 78. And House Bill 78 basically creates a commission on health equity. And it basically brings all the departments, all the cabinet secretaries for the governor, the Department of Transportation, Department of Health, Department of the Environment, the Department of Education, every single agency must make up this commission on health equity, and they must meet at least 4 times a year. They have to have staffing, and they must discuss their policies and how they affect people of color. And they must develop a framework, an equity framework, and look at them through a health equity lens. And we define it in the bill. So that bill actually was very difficult to pass, because in the bill, I have a preamble. And the preamble of the bill actually has a lot of whereases. And the whereases, you know, for example, one says, whereas race is a social construct with no biological basis that artificially divides people into distinct groups based on characteristics such as physical appearance, ancestral heritage, cultural affiliation, and the social, economic, and political needs of a society at a given period. And then it goes on through the history of racism and segregation, which means that you have to accept that this happened. We must first accept it, that racism is alive and well. So my Republican friends in the Senate did not like the preamble, and they stripped the preamble from the bill, and they took a vote. So when it came to the House, I put back the preamble, and I got together with the Black Caucus, that I'm a proud member, and the Latino Caucus as a Black Latina. And we said, I'm sorry, this is staying in. This is our history. You cannot deny it. So we put it back in. It went back to the Senate. They had to vote on it with the preamble, and is now at the desk of the governor. Because I believe that in order to move forward, you have to know your past. You have to know the history. You have to know why it is that we have all these health disparities as well. And the last bill I put in is House Bill 309. And House Bill 309 requires a report card that the Department of Health and the Office of Minority Health and Health Disparities must publish every year. And that report card has to have all the different illnesses, break it down by ethnicity. It also has to tell us, look at the workforce in Maryland, how many Black doctors we have, Latino doctors we have, nurses, how are we represented as well. And the bill, the report card, it requires must be published every year. And it actually has to also requires them to work with the IT department to be able to collect racial data in every single department. So that bill also passed. And the final bill I put in was House Bill 123, which actually expands telehealth, and it requires reimbursement, especially for audio only, which is so important for our communities. So it wasn't easy, but we did do it, and the governor now has to decide whether to sign those 4 bills.
Impressive, Delegate Melnick. I presume that if we went to your site on the state legislature's website, Maryland, we would be able to find these bills.
Absolutely.
I consider them model legislation, and I'm sure my cohorts in the legislatures across this nation who are viewing will want to certainly use your work, your fantastic work there.
Thank you.
Right. Dr. Maybank, the title of this town hall is Racism as a Public Health Crisis. Recently, the CDC made a statement supporting this notion. Can you tell us how the AMA's efforts and the creation of the center addresses this notion? What activities has the center and your team taken to address this?
Absolutely. So first, I want to acknowledge Representative Pena Melnick. I want to say it. Is that right? Like amazing. So we need more of that everywhere, because that is really helpful in the advancement of equity across the country. And I'm going to be more specific about it because I think this is really important to point out as somebody who's a physician, who's somebody who's worked most of their career in public health and public health departments, and now in the healthcare sector. Policy is absolutely critical. And so your points about, and I'm going to answer all the questions, so don't worry, Representative Mitchell. I'm going to get there. There's a point to my madness here. But to really elevate the data piece is absolutely true, right? We need to use data. We need to use it better. We need to have better funding for data infrastructure, as well as opportunities for data sharing across sectors, and not only sectors of transportation, public health, medicine, but also healthcare. So the better these data can communicate, the even more impactful the data can be. But also the challenge and opportunity with data is just also making sure it's going to be used correctly, right? We always have to be concerned about that. And I think your points that you put forward, that we as AMA also did, we passed policy this past fall, 1, to name racism as a public health threat, 2, to get rid of racial essentialism. So to really basically name racism as race as a social construct, not a biological construct. Race is still very much used as a biological construct in medicine, and that's really harmful. It excludes many Black and brown people from proper treatment in the way that they should. So the fact that you highlighted that, you kept that in, you advocated to keep it in, is to me quite remarkable and very important. And then we also passed another policy on ridding race as a proxy for biology and for genetics, because again, race is a social construct, and we really need to focus on those systems. How can we use our data to better understand the impact of racism, of sexism, homophobia, classism? Those are the where we need to get to as it relates to data. To bring up the points about, I think, the Commission on Health Equity, the importance of the collaborated and coordinated work. We have pushed a lot in many places across this country to really start to, get people to see that all policy is health policy, really, at the end of the day. And so the approach of kind of the health in all policies approach, which was put forward by the World Health Organization years ago, has been embraced by other countries, but not really well embraced here in this country. So to see that kind of legislation put forward, the requirement of looking at what are the health impacts of these agencies coming together, I think is extremely strong movement. And so for us as the AMA, one of our strategies is really pushing healthcare, who tends to operate and focus on the hospital and the doctor's walls, to move and push more upstream to really better understand this broader context of what creates health, this public health approach. So I think COVID has really elevated during this time, this segregation between healthcare and public health. So ways in which policy can help support bringing the two together, I think is going to be really critical in order to advance and to support equity and to help rid of racism and dismantle racism in our system so that we can work better together, as well as build systems of accountability. And you even brought up about accountability of the mandates that, folks need, if in order to get their license, they need to do that. That kind of accountability is absolutely critical, because we all know there is resistance. There's lots of resistance that is building right now as the more across the country, and it's showing up in so many different ways. And we need to be much more, I think, collective and coordinated in these declarations of racism as a public health issue, so that we can really fight and counter these resistance in the ways that you have. The other just last piece of work that we're doing as AMA is around the truth, reconciliation, and healing work, understanding that we have to look at the impacts of the decisions that we made as an institution, as AMA. It's been around for 147 years, and all the harm that we have created. One of our initiatives is called the Flexner Report of 2010. And that particular report actually not only really changed medical education, where it was just focused on basic and clinical science, not on the social context of people's lives, but it also recommended the shutting down of the 5 of the 7 Black med schools, that were existing. And that impacts the number of physicians that are here even to this day, and the lack of diversity amongst our physicians. And so we need to take responsibility for that. We need to account for, what harm has that caused? What is the cost of that harm? And then what do we need to do to repair that harm, right? And I think that is where we are in our point of reckoning in this country, and to where we need to be as institutions, and where policy needs to go as well to hold accountability. You're on mute, Representative Mitchell.
I'm impressed, as I am with those who are viewing. They've already put up links to your bills, Representative or Delegate Melnick, as well as articles related to it as well. I have a question for both of you here as we go on. As we continue to think about how we move towards health equity, who have been your partners and allies in this work? How are you incorporating the voice of communities of color collectively to emphasize this? Go ahead, Dr. Maybank. Why don't you go first?
Sure. I mean, several ways, and I think we're still building out those ways. Critical to equity work is centering the voices, ideas, not only centering, integrating the voices and ideas of those most marginalized in our country. That is a primary tenet of being able to advance equity, no matter, even if it's not health equity, but health equity too. And so we have been working specifically right now, headquarters is located in Chicago, New York. And we have now partnered on an opportunity called Westside United, where we're doing collective upstream investment of several millions of dollars with other healthcare institutions within the neighborhood to provide upstream opportunities such as job development, economic development, and then working to understand what are the social impacts. How does that really impact on like life and health outcomes over time? It's completely community driven and it's community led. So the residents of West Side are the ones who are really organizing the opportunity, and we're able to come in to be a part of this and to help support in that way, along with the health department, along with the mayor's office, as just one example of how we are working collaboratively within a city. Now, other work that we're doing, I mentioned before that we have the history of exclusion of Black physicians. So we are intentionally working and making sure that we are helping support, do partnerships in different ways, sharing power in different ways. AMA is a pretty well-resourced institution. So how do we share that kind of power, understanding not all institutions have that, but still have the power in terms of expertise and knowledge and relationships and centering that. And so we are making sure that we have consistent communication, building the infrastructure to make sure that we are coordinated with many of these physician groups that we are engaged in. And I think in terms of unexpected, allies, that comes in many different ways. There are folks who are around the table, and I'm sure this happens within caucuses and within legislatures, that sometimes you would not think that they would be on your side. I have been blessed that since coming to the AMA, and I was concerned before coming to the AMA if I was going to have this support. But internally, we have a great, as example, general counsel, total ally, unexpected beforehand, but complete ally in all the work, and can help kind of troubleshoot and how to move things forward in a very meaningful way, and how to engage with internal partners of the organization, but also external. And I think, the important thing for us as the AMA is, and myself really in doing this work, is that I have to communicate oftentimes because I am in environments that are, as many of us are, that are predominantly white. And I have to make sure that I communicate that I'm not just always looking for an ally, because sometimes allyship comes off a little passive, and folks are waiting for us to call them in. And I really kind of put the declarative forward that I need accomplices, I need co-conspirators, to help do this work, to help push this movement forward that has been left to us as a legacy by all those who came before us that opened doors. And so I think a lot of this work is, how do we want to show up, choosing as leaders, how we want to show up in this moment, so that these opportunities don't pass us by. Because I think we're at a moment where many doors are open, they're aligned, and we need to push as fast and as forward as far as we can.
Delegate Pena Melnick, would love to get your comments on that.
I agree with you, Dr. Maybank. This is the time to act. We cannot warm the seat. We owe it to our ancestors. Okay, life is too short. That's one thing we learned about COVID. It's all about perspective. For Maryland, it really helped that we have, for the first time ever, a Black speaker, and she developed Adrienne Jones, and she developed a Black agenda. Yes, she did, and was very serious about it. So, she made these bills part of her agenda. Also, we passed a bill that provides $500 million to the HBCUs because they have been underfunded, and the governor had vetoed it, and we came back and did a veto override. So she's very committed to the communities of color. I think that in building a coalition, because that's what I had to do for like almost 7 months to pass these bills. For example, House Bill 28, which requires implicit bias training. The doctors do not want to take another course. They don't want to be mandated to take in a course. But when I use the data, and sometimes you have to shame people to do the right thing, and I'm not going to, apologize about it. And we sat down like we're talking right now, and I showed the data. How we are, Black women in Maryland after giving birth are dying, at a higher rate than white women, and that's not acceptable. How when it comes to cardiovascular diseases, when it comes to other cancers, asthma, our children, our numbers are horrible. So we had an open discussion, and they got it. I also was able to bring the insurers, which in Maryland, it is Care First, Blue Cross Blue Shield, and Kaiser. They have most of the market, and they actually supported it. Believe it or not, AARP, Alzheimer's Association, Johns Hopkins School of Medicine, as well, the Attorney General for Maryland, even the Rural Association, the Public Justice Center, the Department of Health, the health officers. I try to get all those voices to support these bills because they also were able to contact the senators and delegate and send emails and schedule meetings and talk from their experiences, what it's like to treat these communities and how the health outcomes are so poor. And I met with a couple of doctors, African-American doctors and one Latina. And I said, what will you do differently? Tell me what you think we should do to help your colleagues get it. So they help in the drafting of it as well. And then when we came to the hearing, they came and they testified. And it was powerful to hear from these doctors what their experience was like, what they witnessed. Very different than from me to present the testimony, because they're respected. Not only are they respected, but they're living these experiences. They have patience. So it does take a village, as I like to say, in order to get these bills through. And I would not have been able to, first is just if the speaker didn't make it a priority, but most importantly, if I didn't build coalitions. And lastly, in your legislature, you have caucuses. So I am really blessed that I'm a member of both the Black and Latino caucus. So they embraced it. And they helped, and that's between those two caucuses, that's a lot of members that also were able to advocate when they met with the speaker and the president of the Senate.
Well, both of your comments were profound. Let me propose this to you both. We have a number of local governments and even legislation here in the Georgia General Assembly to deal with racism as a public health crisis. There are those, of course, who disagree with that notion, and they point out issues such as we may find that the disparities are about, for example, vaccination hesitancy, different cultural experiences as to why we have some of these disparities. What do you say? Let's start with you, Dr. Maybank.
Yes, so first to the comment that racism doesn't exist, I think that might have been the first thing, but if it wasn't, I'm still gonna answer that one. Because we just, we're coming off of, AMA. We had a horrible podcast that was put out by our Journal of American Medical Association by two white men who were discussing structural racism, who knew nothing. They weren't experts on structural racism. And really the underlying premise to me was that, to kind of deny racism is existence. And from a scientific point of view, we have plenty of evidence to demonstrate that racism does exist. And not only does racism exist, racism is the fundamental cause of why our health inequities exist in this country. When we look at disparities, and some were already highlighted, the greatest disparities that we see are amongst race. Those are where the greatest gaps are in terms of who's doing well and who's not doing well. And Blacks and Latinx and Native Americans, Indigenous folks are usually suffering the most as it relates to health outcomes. But we have to look at the system itself of racism and just not race. And so there are numerous studies in that we can put articles in that have been done. I say that I'm no longer at the point of kind of justifying whether racism exists and whether it impacts health. We know it impacts health from the physical context. It increases folks' cortisol and stress levels. It increases inflammation in the body, which then becomes destructive for the body over time. It increases our risks for getting chronic disease such as heart disease and diabetes and all of these. And all these experiences that our communities are going through right now, experiencing that trauma, even via the television, is traumatic on the human body. And we embody that kind of harm, and it causes health impacts to our physical body. So racism exists. Structural racism is a fundamental cause of why these health inequities exist. The evidence and the science tells us so. And we have much documentation for that, first of all. And then your second question was around like the hesitancy and what do people say in terms of, the experience of what's
cultural experiences, exactly.
Right across the country. And again, so, many of us at the front line of equity and many physicians who are doing work around, trust. And we hear these messages, Black communities don't trust or communities of color don't trust. And I think that that's true. There's truth to that. We have history about that. It's beyond Tuskegee. I try to push sometimes Tuskegee to the side just a little bit, not because it's not relevant, but to understand that people's immediate experiences have caused them to not trust the medical community or the medical environment or technology, because there is experimentation that goes on in different ways, or at least exploitation that goes on. There is the experience that people don't feel like they're heard or listened to, that the delegate just mentioned about Black women who are more likely to die as a result of childbirth because they are oftentimes not listened to. So those are real and immediate experiences. And so the question isn't about, always like, is it our trust? Because then that puts the blame on us, the onus on us as people of color, that we're not doing something. It's because we don't trust why we're not doing it. No, it's like, let's look at the institutions and their lack of trustworthiness. And then what is the root of why they lack trustworthiness? Oftentimes it's the systems of oppression and exclusion that have prevented people from going. So what is the role of the institution? What's the role of government? What's the role of healthcare? What's the role of public health? What's the role of education? What do they have to do differently that allows them and allows people in communities to trust them more, so that they do feel more comfortable seeking care, getting new opportunities that oftentimes they feel before they've been excluded. So we have to understand, like, the fears are rational, for people in terms of their hesitancy to want to engage and get treatment that's available.
Delegate Melnick, I know you have run into colleagues who have suggested to you that there really is no significant racism in healthcare, such that it should be made a public health crisis. I know you have run into the notion that this is all about personal responsibility.
That's right.
And as even a questioner put in the chat, how does personal responsibility play into health equities? What did you say to your colleagues and to the questioner?
You don't really want me to tell you what I really say, but I'm going to be diplomatic here, and just say that this is the reason why I fought so hard to keep the preamble that declares racism as a public health, because we have to understand that racism is rooted in the foundation of America. From the time slavery began in the 1600s. How can you deny that? Like Dr. Maybank said, that is the history. You can't deny it. When you look at, Jim Crow era, to the declaration of war on drugs that eventually led to mass incarceration of Black people, it has remained a presence in America's society, subjecting Black, Indigenous people, people of color to hardship and disadvantage. I tell my colleagues, you and I are not the same. We didn't start with the, same equal footing, okay? You have to go back to slavery, to, segregation, when we couldn't buy, homes, when we couldn't find work. All of that is related. When you look at, how racism causes persistent discrimination and disparate outcomes in many areas of life. And I tell them, look at housing, look at education, look at employment, criminal justice, incarceration, the family stability in our community. The economic opportunities are not the same. Access to healthcare is not the same. Public safety is not the same because of where we live. The environmental safety is not the same. You know, inadequate nutrition, even voters' rights, all of that, it's not the same, and you can't deny it. So cut the, you know what, with the personal responsibility, because the data is there. If you choose not to accept it, then that's on you. But the responsible thing to do, if you're going to use the word responsibility, is to look at the science and the data, and they speak very loudly how we have all these disparities, not just in healthcare, okay, which is why, you know, you have to look at systemic racism and try to address it with a wider lens and an equity lens, which is so important. And this is the time. So I urge the members of the caucus to put in these bills, to have the uncomfortable conversation that people do not want to have, but you must have them in order to start addressing these issues. And I have to tell you, Dr. Maybank, I put in a bill that it was the first of its kind in Maryland 2 years ago that created the Maryland Lynching Truth and Reconciliation Commission. Is the first in the United States to look at the number of people, of lynching cases, like 40 something in Maryland, that we have never addressed, that we have never admitted that it happened, that we have not honored those victims and their families. And we work closely with the HBCUs, and they're part of the commission. And the commission, actually, the Lynching Commission, just got a $300,000 last year grant to do their work from the federal government. And that is also a way for us to start having this conversation, to look at our history and to address it, not just having markers, but having the actual discussion. Why did it happen? And how can we prevent that from happening again? Because it is happening in other ways. And this is the time to act.
Impressive. Dr. Maybank, I see you're ready to jump in again, but let me just ask you here. I heard the notion in the debate concerning similar legislation here in Georgia, and statistics were disseminated that suggested that even if we had more physicians of color, the outcomes seemed to not change if those who were subject to maladies, illnesses, it seemed to suggest that even if they had physicians of color, the outcomes didn't necessarily change. They seemed to still, in some cases, not be served as well as other communities. And it reminded me of the debate that we have going on with policing. The likelihood of you being over police did not change if the police were of color. What do you say to that?
Yes, so several things. One, so the total solution is not that we have, that having a Black doctor or having a doctor of color is going to be the absolute end all and be all of racism is going to go away, and everybody's health is going to be good. I think diversity is absolutely critical. It's fair and it's just, right? We all deserve opportunities, and all communities deserve opportunities to become professions of our choice. But we know that we are excluded. We do know that there is some evidence that shows greater satisfaction. You're right about outcomes. There's still not enough evidence to show that the actual health outcomes change, but there is greater satisfaction. We do know that as it relates to diversity. Now, the larger issue, though, at hand is at the root of this, and I think the delegate, has laid this out well, is structural racism, and that's deeper than just whether or not diversity changes. That's embedded into entire society. Racism, by definition, right, is a system of power that assigns values, structures opportunities, disadvantages people of color, and advantages those who are white. It saps society of its energy, and it wastes human resources. That's the definition of structural racism. And if we don't change that, then you're absolutely right. Changing the diversity of the physician pool won't do much of anything. It won't be the total solution, let's put it that way. And it shouldn't be the responsibility of Black and Brown physicians to have to change and impact the health outcomes of Black and Brown people. We are all born equal, right? And so everyone, all physicians should be able to care for patients in equitable ways, equal and equitable ways. And I think that's the message that we have to move forward. And the other part of it that I say that usually gets people more comfortable, because really the fuel for racism is white supremacy. And we don't talk about that enough. And the hierarchy of human value, and just to break that down so that, because I know people become very tense over that, is the hierarchy of human value based on skin color, with white being on top. And I saw an excellent video on Twitter today. Jane is her first name. I cannot remember what her last name was, but it was an audience of, identifies as a white woman. She says this, the audience was predominantly white. And she asked them, how many of you would want to be in the shoes of a Black person? None of them raised their hand. She asked it again. How many would want to be in the shoes of a Black person and people of color? And she said, well, that means then you do know their experience. You do understand what they're going through. And so we do need to have challenging conversations, and we do need to push each other, because I think there's a lot that people see that they're not admitting to. And I understand the scariness of it. And I understand this moment when a lot of people are afraid of making mistakes and saying the wrong thing as well. Thanks, Jane Elliott. Thank you for whoever put that in the chat. I appreciate that. They're afraid of doing that. But one of the things that we can do, and we need to do so that we can have these conversations more productively, is start building an analysis. There is so much out there to read. I saw someone put in the question about race being a social construct. Race is not a there's nothing biological about race. The Human Genome Project proved that, provided that, nothing. Race was completely human created in order to divide people up and in order to really sustain the system of slavery. So it's totally social construct, but there's a film called Race, the Power of Illusion that I highly recommend people to look at. It's actually a little over 10 years old, but still great. Race, the Power of Illusion talks about the evolution of race, but there's so many materials out there now, videos, reading opportunities to really learn more about the construction of race and racism in this country, and not just for Black people, but really I think we also have to name the invisibility, oftentimes also, of Indigenous people in this country who experienced genocide and the grab of resources for their land, for the sake and the production of capitalism. The same for labor. Capitalism could never have happened without the free labor of slavery. And those things we have to get real about.
Wow, impressive. Before I go to Senator Shindo, let me just remind those who are on our town hall that if you have a question or comment, you may do so by placing it in the chat so that we can recognize it. Senator Shindo, the floor is yours with your question. Unmute yourself, Senator.
Okay, there we are.
Great.
Okay.
Glad to have you with us.
Oh, thank you, Representative, and thank you, Dr. Maybank. This is a very long overdue conversation, I think, as we listen and so forth. But congratulations, Dr. Maybank, on your new role at the American Medical Association. As you stated, Native communities, for us, we often face challenges gathering information and receiving culturally relevant care due to insufficient data. How has the Center for Health Equity engaged or going to engage with Native communities and providers to address these challenges?
Absolutely, thank you for that question. There are many ways. So one of our key partners is the Association of American Indian Physicians, and we meet with them on a regular basis. So the president, as well as their CEO and other members, just to engage, to hear what is happening and what are kind of the gaps, but the opportunities for us to partner, the opportunities for us to use our advocacy voice as AMA to help elevate issues. And as an example, when COVID first came out, there were definite challenges even though funding was earmarked for our IHS, it took a really long time for it to get there and for it to reach communities and Indigenous communities across the country. And so we have done lots of advocacy at that point in time for sure, and still continue to make sure that those funds got released and released in a timely manner and just manner, and really just elevating to the federal government and to other folks that we are connected to this challenge, and to make sure that we use the power of our AMA voice to do so. We are also going to be working on educational modules to also better elevate the experience and the realities of Indigenous communities, but also the power of Indigenous communities. Because I think it's not helpful to also view Black and Brown communities from a needs-based perspective, but more a strength-based perspective. Communities have been highly resilient over time and have survived, deserve the opportunity to fully thrive. But I believe we also need to change the narrative and set the power and examples that have happened that have been really great. One, and you may be very familiar with this, you know, we know a shining example recently in terms of vaccination in the Navajo Nation. The Navajo Nation had some of the worst case rates and death rates as it related to COVID. However, in preparing and anticipating for when the vaccine was going to become available, the community really came together on so many different levels in partnership with IHS, the tribes, the leaders of the tribes, and all that coming together to really think through planning. And so now the Navajo Nation has some of the highest vaccination rates in the country because of that collective opportunity and power that exists within the community. So I thank you for your question, and there's always more to do to create visibility and to help support exposing and unearthing like the challenges and opportunities with Indigenous folks.
Thank you.
You're welcome.
Anything more, Chairman Shendo?
No, I let others ask questions as well. I appreciate that.
Great. Well, thank you. And I tell you, your words have certainly made an impact, Dr. Maybank. I see in the chat, Representative Calvin Smyrie, the Dean of the Legislature, was moved to ask the name of the film that you cited, and he was answered.
Yeah, somebody put it there, Race the Power of Illusion. Wayne put it. Thank you, Wayne.
I will certainly go there to look at that film myself. It was a powerful commentary. Just to talk about my colleague, Calvin Smyrie, he's the longest serving legislator of color in this nation. And glad to have him with us. Delegate Pena Melnick, let's get your comments before we go to any others.
I think that, you know, the doctor said it beautifully. I don't have much to say. She added exactly what, you know, what I agree with, what my work reflects. And I think that we need to have the conversation about racism. We cannot just assume that it is all about access to healthcare. That's not where it stops. You know, people have to go to the doctor, but they also need a place to live. They also need a job. Okay, they need to live in a place where the air is clean and their kids won't be suffering from asthma. You know, it's really systemic, and it's not just one issue. And we need to pay close attention to those social determinants of health. And as policymakers, our policies have to reflect that, you know, to make sure that people have access to housing, you know, that they're able to make a good living, that if they are essential workers, they have the protection they need at work, and that we budget for those things. So we have to look at things in a holistic way, not just, you know, one single issue. And we need to be committed to that so that we can elevate these communities, because it's the right thing to do, simply.
Absolutely. We're going to lose Dr. Maybank at 2 p.m. Before she goes, one of the things that I love about the Quad Caucus is our ability to get together and solve these issues. I believe if we come together as a united Quad Caucus, so many issues that we can deal with. Will the American Medical Association have the access that you have to the great work with the Center for Health Equity? Is there a way that the center could help the Quad Caucus build networks with our state medical society so that we are approaching these
Love to do
issues in a coordinated effort?
Yes, I think we would love to do that. I think that would be a tremendous opportunity. Yes, I'll say that, and let's talk more. But I was thinking that actually through the call. So I would, yeah, let's touch base.
Great. Dr. Maybank, we will be in touch.
Okay, thanks
And
everyone.
I'd like to invite all the Quad. Let me just first of all thank to all our speakers for their valuable expertise. Thank you so very much, Dr. Maybank. Thank you, Delegate Pena Melnick. This was invaluable. I understand we have over 300 participants in the town hall, and I believe we probably could have gone on at least another hour. I'd like to invite at this time all the Quad leaders on camera with me as we announce a joint statement acknowledging racism as a public health crisis. Kyle, Daniel, Benny, please turn on your cameras. Let me just call on all of you to say a few words, if you will, before we get to the consensus statement. Since you're right there, Senator Shindo, go right ahead.
No, thank you again for organizing and the sponsor and the speakers and all of us that, like I said, you know, this conversation is long overdue. And I think the statement reflects the Quad Caucus in terms of our work ahead in working with our states, respective states and colleagues in our legislature. So thank you again.
Great. Senator Avisoto.
Thank you very much, Representative. And first of all, I wanted to thank very much one of our the leaders in the National Hispanic Caucus, the state legislatures, which is Delegate Pena Melnick, for everything that she has brought to what has happened today, as well as Dr. Maybank. These are conversations that are long overdue and need to be happening on a consistent basis. Representative, you're so right. We've just scratched the surface in this hour that we've been here together, but this is a continuing conversation we need to be having. This last year, the National Hispanic Caucus of state legislators passed an emergency resolution declaring institutional racism as a public health crisis. And in fact, Senator Linda Lopez from New Mexico was one of the co-sponsors. I know that she is here today participating as well. And we're a proud partner with the Quad Caucus, and we're going to continue to work on this issue. This is truly an important issue that we need to be able to continue to work on, and recognizing the uniquenesses within each of the Quad Caucuses of what has happened, much of which was discussed by Dr. Maybank, but also, as was just mentioned in the chat, the fact that within the Latino community, a lot of our members or our constituents who are undocumented don't even get access to a lot of the healthcare that may be provided in a disparate manner to other communities, are completely excluded to certain communities within our organization. So, but thank you all very much.
Thank you, Chairman Yamashita.
Yeah, thank you very much, Representative Mitchell, for moderating this, and thank you also to your panelists for such an important conversation that is needed and well needed. NAPACSL values the partnership in the Quad Caucus. On a personal note, I have been in the Quad Caucus from its inception, and I value all my friendships that I've made over the years. Benny Shindo and I have been, I think, almost from the beginning, working together. And, we understand that all of us have had a hard time this past year in light of what's happened. And we value the friendship that we've created over the years with the Quad Caucus, and we pledge our continued support. In the wake of anti-Asian bias and violence, this is a very important time for all of us to come together. So thank you very much.
Well, I want to thank all of you and to our presenters, certainly Dr. Maybank and Delegate Pena Melnick. Wonderful presentations, and certainly the information that you provided will pay dividends not only within your organization, within your legislature, but throughout our nation. And I sincerely believe that it is through our partnership, through the Quad Caucus, that we can make a difference, not only in this issue, but so many maladies, so many other issues that is confronting this nation. The consensus statement is been placed such that you can see it, declaring that racism is a public health crisis that impacts all communities of color. I understand that will be distributed to us all, and maybe it serve as motivation for legislation like Delegate Pena-Melnick, as well as policies that Dr. Maybank talked about, and serve us well as models for all our legislatures as well. I want to thank again Amgen for their support of this very important event. And finally, I want to thank you, to all our attendees, for participating in today's webinar. As a reminder, a recording of today's event will be provided to all caucus members. Once again, I'm Billy Mitchell, glad to be with you, glad to serve with you, and glad to be addressing this very important issue. Thanks again.